Good morning, everybody. Happy Tuesday morning. Welcome to PCH Grand Rounds. Our speaker this morning is Dr. Ben Wright. Dr. Wright is a native of Mesa, Arizona. He's a Sun Devil and a Wildcat. Who are you going for on Saturday? Sun Devils. Good. He went to undergrad at Arizona State University and then completed medical school at University of Arizona. He then went on to University of Utah for his pediatric residency, and then went to Duke University for his fellowship in allergy and immunology. He's a Blue Devil as well. He's been at PCH on staff since 2015. He's been very active in writing and publishing and has been awarded numerous grants. He's also the lead author of the chapter on eosinophils in Nelson's textbook. So please welcome Dr. Ben Wright.
Thanks, Micah. It's great to be here, and I'm excited to talk about some of the research we've been doing in the clinic and in the lab. So hopefully the title of my talk will make sense as we move through these slides. We have a lot of information to cover. So first, I have no disclosures. I work for both Phoenix Children's and Mayo Clinic. And the objectives of this talk are to talk about the risks and benefits of emerging therapies for IgE-mediated food allergies, as well as to discuss novel biomarkers that are under investigation for eosinophilic gastrointestinal diseases, specifically eosinophilic esophagitis. So we're going to start off with a case. We have a 4-month-old child with a history of severe eczema who presents for evaluation of food allergy. Mother reports that she suffered diffuse hives within minutes of tasting a small amount of scrambled eggs at the breakfast table. She was given Benadryl and had resolution of symptoms within 2 hours. And the mother denies any history of throat swelling, respiratory distress, or anaphylaxis. There's a family history of asthma in the father, but otherwise no other history of atopic disease in the family. She's in an allergist's office, so we perform skin testing, and it's positive for egg. So what are the elements of this history that are suggestive of an IgE-mediated food allergy? I'll give you a chance to call them out if you can think of them. Hives, okay. Anything else? Family history of atopy, yes. So the other thing is the trigger. So egg is a common trigger of food allergy. It's one of the 8 foods that account for 90% of reactions. The other thing is timing. So rapid onset, rapid offset. When someone tells me that their child is having a food allergic reaction, but it happened 24 hours after ingestion of the food, that makes me suspicious. Symptoms. So you mentioned hives. These are characteristic of an IgE-mediated reaction, and about 85% of reactions are associated with cutaneous symptoms. And then risk factors. So the age of the child, as well as the comorbid atopic dermatitis. So what's the next step in the diagnostic evaluation of this patient? So I hope everyone's familiar with this. These are the new peanut allergy prevention guidelines. So this child is at high risk for not only developing egg allergy, which commonly resolves throughout childhood, but also developing peanut allergy. So she has severe eczema. She also has an egg allergy, which means that she's a setup for developing peanut allergy. And in those patients, they should undergo skin prick testing to peanut to try to figure out if they've already become allergic, whether they're sensitized, or whether they're okay to introduce at home. And the guidelines have introduced 2 different approaches. One is to perform peanut-specific IgE testing, which is something that you could do as a pediatrician in your office. This is something that you may do if you have ready access to an allergist and can get them in relatively quickly for testing. Subsequently, if the IgE level is greater than 0.35. If the test is negative, you're home free, essentially, as long as they can introduce the peanut at home and have them consume it on a regular basis. If we see them in the allergist's office, or if you made the referral immediately, we'd perform a peanut skin prick test. And then we have different sizes of the skin test that dictate what we do. If it's 0 to 2 millimeters, we have them introduce at home. 2 to 5 millimeters, we will introduce in a supervised setting. And then if it's greater than or equal to 8 millimeters, there's a 95% chance that they already have an established peanut allergy and should avoid it. And we'll talk a little bit about the rationale for these guidelines. So we performed peanut skin prick testing. This is actually a patient I saw in the clinic, and the skin testing was negative. So I gave her instructions to introduce 6 to 7 grams of peanut per week in 3 divided feedings, as well as some recipes on how to do that in a 4-month-old, which is not always the easiest thing. And she was given topical corticosteroids for her atopic dermatitis and told to avoid all forms of egg for now, because her egg skin prick test was positive. So peanut allergy is on the rise. It's increased in prevalence from about 0.4% to 2% over a 11-year span, and it's the leading cause of food-induced anaphylaxis causing death. And for a majority of patients, about 80%, this is going to persist for the rest of their lives once established. This is just a graph from the NIH showing the increasing prevalence of food allergy, and you can see that it's disproportionately affected young children. So the way that this works is that your peanut protein gets presented to your antigen-presenting cells, dendritic cells, which present peanut protein to the peanut-specific T cells that drive a Th2 process characterized by elevated Th2 cytokines, IL-4, 5, and 13. This influences B cell production of peanut-specific IgE, which binds to the surface of mast cells. And when they are triggered by exposure to an allergen, cross-linking occurs that results in release of vasoactive mediators such as histamines, leukotrienes, cytokines, prostaglandins. And that results in the symptoms of anaphylaxis that we're all familiar with. So airway obstruction, hives, low blood pressure. For systemic symptoms, local symptoms such as swelling, nausea, vomiting, cramping, and diarrhea. So we're going to talk a little bit about, I think it's important to see this from the patient perspective. This is a video of some parents talking about their children's food allergies.
I think the greatest misunderstanding is that food allergies are like lactose intolerance.
Oh, my brother's, can't have milk either. He gets a stomachache.
People think of, seasonal allergies and not really life-threatening allergies.
I have to be vigilant in order to keep her alive.
Every activity has to be evaluated for its potential risk.
There's definitely times when they feel isolated because they have to be.
Designated areas in the kitchen that nobody can use. He's got his own refrigerator, he's got his own microwave.
I'm frustrated by people who don't want to understand it.
That's difficult. It's really difficult to try to get somebody who doesn't get it to get it.
Every day. I worry every day.
She leaves for school every day with her dad, and I always close the door and hope that it's not the last time I see her.
You don't want your kids to know you're afraid they're going to die, but you want them to be prepared.
I have the same worry that somebody's going to slip up, and that we don't get there in time.
It's not easy.
Okay, so this sort of portrays some of the feelings that the parents have I have a food allergic child in my home, and it's constant worry, and there's anxiety over going out to eat and being at places where people may not be as cautious, and it only takes a small amount of food protein to induce a food allergic reaction. So what's fueling this rise in peanut allergy and food allergy in general? Well, I think we have to look at some of the recommendations that were passed down actually under the guidance of some allergy experts in the American Board of Pediatrics. I know in my training I was counseled to give advice to patients regarding introduction of allergenic foods. Some of you may even provide some of this advice. In the year 2000, the AEP provided their recommendations on hypoallergenic formulas and breastfeeding, and in that they made some statements about when to introduce highly allergenic foods. They said, conclusive studies are not yet available to permit definitive recommendations, but it seems reasonable. So that's sort of their caveat, saying we have no evidence for what we're about to say, but this is what we're going to say. They said solid foods should not be introduced into the diet of high-risk infants until 6 months of age, with dairy proteins delayed until 1 year, eggs until 2 years, peanuts, nuts, and fish until 3 years. So it's easy to remember, right? milk at 1, eggs at 2, peanuts and tree nuts at 3. And I think because it was so easy to remember, that's what we told all of our patients. But what we're finding out is delaying oral introduction of allergenic foods can actually be very harmful and may have fueled the rise in peanut allergy in particular. We're going to watch another news report about a recent study, the LEAP trial, that hopefully all of you have heard of. Oops.
A new medical study out today could transform the way doctors prevent peanut allergies. Turns out keeping kids away from peanuts may be the wrong thing to do. Here's Dr. John LaPook.
8-year-old Evan Woolen is enjoying a peanut butter sandwich. When he was a baby, his mother Kerry thought this would never happen.
He was borderline allergic to peanuts, which I personally think would have developed into a peanut allergy.
At 10 months, Evan was enrolled in a study challenging the idea that peanuts should be avoided in the first year of life.
I had quite little bits of peanuts. I had this peanut snack, which I had to have about 3 times a week.
Researchers followed more than 600 British babies 4 to 11 months old who were considered at high risk of developing peanut allergies because they had eczema or an egg allergy. One group avoided peanuts. The other, that included Evan, ate a small amount of peanut protein every week. After 5 years, the kids eating peanuts had 81% fewer peanut allergies than the group that didn't eat them. That's exactly the opposite of guidelines from 15 years ago, withdrawn in 2008, that recommended excluding peanuts from the diets of infants and toddlers at high risk for allergy.
I think this should change clinical practice.
Dr. Hugh Sampson is an expert on pediatric allergies who is not involved in the trial.
I would encourage people with babies between 4 and 8 months of age to come in and get evaluated and get started on peanut protein if you're at high risk.
Today, Evan has no signs of peanut allergy. In fact,
My favorite food is peanut butter, which does have a lot of nuts in it.
researchers excluded children who were highly allergic to peanuts based on special skin testing. So Scott, Dr. Sampson suggests that any strategy by parents or other caregivers to give peanuts to either toddlers or infants should definitely include input from a health professional. John, thanks very much.
Okay. So what led to the findings of this group, the LEAP study, where they found that early introduction of peanuts can be preventative of peanut allergy? Well, first it started with an observation. And what they found was that children who were Jewish in the United Kingdom had much higher incidence of peanut allergy than those who were of the same ethnic background in Israel. And in fact, they found that the children in Israel were consuming a peanut protein containing snack called bamba, which is a boiled form of peanuts, kind of like one of these little puffs that are given to infants. And so they did a study looking at the epidemiology of peanut consumption in both environments, and they found that the prevalence first of peanut allergy in the UK was 1.85% versus 0.17% in a similar population living in Israel. So a significant difference in the prevalence of peanut allergy. And they found that peanut was introduced earlier and more frequently in larger quantities in Israel than in the UK. And when they compared median consumption, it was about 7.1 grams in Israel versus 0 grams in England. This led and served as preliminary data supporting the LEAP trial, where they randomized children to early peanut consumption versus the standard of care, which was avoidance. And the main findings of this trial were that after 5 years of early peanut consumption, they showed that high-risk infants that consumed peanut had rates of allergy about 3.2% versus 17.2% in the avoidance group. That's in the intent to treat group, which means that when you randomize to treatment versus avoidance, that even if they don't consume the peanut and do what you wanted them to do in the trial, there's still a significant difference. When you look at the per protocol analysis, it's even more impressive. So this means that everybody who actually followed the protocol in the consumption group, the incidence of peanut allergy was only 0.3%. So dramatic differences with early introduction of peanut. So importantly, they did a follow-up trial called the LEAP-ON study, and they looked at the prevalence of peanut allergy in those infants that introduced peanut early during their first 5 years of life after they took them off of peanuts. So essentially what they did was they introduced early for 5 years and they told them to avoid peanut completely. So for 1 whole year, they wanted to assess durability of response, and then they went and challenged each of these infants to find out if these were permanent immunologic changes that were induced by early introduction of peanut. And what they found was that that the changes had persisted. So if we look back at the former slide, we have 17 versus 3.2%, and here we have 19 versus 2%. So 0.3 up to 2.1, really not a statistically significant rise in the incidence of peanut allergy among that population, which tells us that this is a durable response. It's something that's permanent, and it's akin to immunologic tolerance. So back to our case presentation. So I see this patient come back to me who's presented initially at 4 months with an egg allergy, who was at high risk for peanut allergy. We've introduced peanut, and she's back for her eczema care. So she says that she's had successful consumption of peanut for a few weeks, but then she didn't really like it, and so she stopped eating it. And so now I'm worried because her eczema is still not very well controlled. She still carries these risk factors. She's not consuming peanut on a regular basis, 6 to 7 grams per week. And I repeat skin prick testing because I know that about her risk category. And then her peanut skin prick test is 10 millimeters. So she has a markedly positive peanut skin prick test and has now developed peanut allergy, probably that she'll have for the rest of her life. And so there's a very small window in which we can intervene, and I think this case illustrates that point. So I counseled her to strictly avoid peanut. I gave her a prescription for an epinephrine auto-injector and asked her to follow up. So what is the recourse for these patients once peanut allergy is established? We're going to talk a little bit about some of these emerging therapies, including oral immunotherapy.
Ooh, I like this one too.
Food allergies are on the rise, doubling approximately every 10 years. 1 in 13 American children are affected. Altogether, 25% will have a severe reaction called anaphylaxis.
No, because then she won't run.
17-year-old Nicholas Perazio completed the study in 2013. At 9 months old, his first taste of macaroni and cheese landed him in the ER.
You could not even kiss him after you ate a piece of cheese. His entire face would blow up.
Before treatment, his mom, Kathy, was in a constant state of panic.
It's like an alarm, and it felt like it never went off. And then after Carrie, I feel like, I'm sorry. Okay. I feel like, not that the bell stopped ringing, but it's just quieted.
Now Nicholas takes a daily maintenance dose of foods he used to be allergic to, in the form of a cookie.
Do you think you changed his life?
Oh, I know I changed his life.
Okay, so what is this oral immunotherapy? Immunotherapy is based off of the concept that we gradually expose somebody to something that they're already allergic to in the hopes of developing desensitization and eventually tolerance or sustained unresponsiveness. And so somebody comes in, they go through an escalation phase and then through a build-up phase, which occurs over a process of weeks to months, and then for months to years they remain on a maintenance dose of peanut or food immunotherapy, and then in the trials they'll undergo an oral food challenge to assess whether this actually has worked or not. And in some trials they'll pull them off the therapy to see if this change has been permanent. So I'm going to highlight some of the main double-blind placebo-controlled trials that have been performed with egg oral immunotherapy, one of which was something that came out of the Consortium of Food Allergy Research, or COFAR. They did a randomized double-blind placebo-controlled trial that was published in the New England Journal in 2012, where they looked at 55 children with egg allergy from ages 5 to 11. So these children are a little bit older than the ones we've been talking about so far. They randomized them to receive either 2,000 milligrams of egg protein for their maintenance dose versus placebo, and they showed that 75% of the treatment group were desensitized by 22 months. That means that when they once they'd been on maintenance therapy for that period, they challenged them with an oral food challenge, and none of them had clinical reactions. However, when they pulled them off for an 8-week period and re-challenged at 24 months, only 20 28% of these subjects had sustained unresponsiveness. There's been some debate about what to call this. Is this immunologic tolerance that's induced by oral immunotherapy, or should we call it something else? And there's been agreement among the experts that we should call this sustained unresponsiveness, because it may not be quite the same thing as the natural tolerance that we, for those of us who don't have food allergies, develop naturally. So disappointing that this is really something that mostly induces desensitization and in a small subset induces sustained unresponsiveness. However, they found in a follow-up study of these same children that after you've done this for 4 years, instead of 2 years, this sustained unresponsiveness increases up to 50%. So it may be a duration of therapy that makes the difference. In a cohort of children at an earlier age called the Devil Study that was performed at Duke and the University of North Carolina, they did a double-blind placebo-controlled trial of 40 children with peanut allergy, so a different antigen, and they looked at ages 9 to 36 months, so much younger children that are essentially under 3. They also, in addition to randomizing between treatment and placebo, they looked at different doses. So they used a very low dose, 300 milligrams, or 3,000 milligrams for their maintenance dose, and then they assessed sustained unresponsiveness 4 weeks after oral immunotherapy. And in contrast to the findings of the COFAR trial, they found that 85% achieved sustained unresponsiveness and 71% in the high dose. So even the low dose was effective at achieving sustained unresponsiveness. And so essentially what we're seeing is that the earlier you start, the better off you may be in terms of your outcomes. The patients, when they compared a group of children that were treated with standard of care, which is avoidance, they showed that they were 19 times more likely to tolerate peanut if they underwent peanut oral immunotherapy. So this gives us sort of a conceptual view of how the way I see peanut allergy. And on one end of the spectrum, you have somebody who is non-allergic, and on the other end, you have somebody who has an established peanut allergy. And then you have some gradations in between. And there's ways that we can intervene to try to make a difference. In children who have eczema, who are prone to developing food allergies, we can institute emollients and skincare. And this is something that you can do. They've actually shown that children in the nursery who develop peanut allergy have elevated levels of transepidermal water loss. What's happening is that food proteins can go through the skin, and when they go through the skin as opposed to the mouth, they promote a Th2-driven allergenic process. And so by fortifying that skin barrier, we can prevent the development of atopic disease. So Vaseline, Eucerin, Aquaphor, all the things that you're used to recommending to your patients, helping them understand how important it is to close that immunologic door for the development of allergy. So when somebody has eczema or severe allergy, now we're moving in to a different realm. These are children who are at high risk for developing peanut allergy, and we can promote tolerance by early peanut introduction based off the findings of the LEAP study. Then somebody becomes sensitized to peanut, or they have peanut-specific IgE, and they have a positive skin prick test, but it may not be that big, or they may not have clinical symptoms of peanut allergy when ingesting peanuts. But once peanut allergy is established, really the only emerging therapies that are available are oral immunotherapy, sublingual immunotherapy, and epicutaneous immunotherapy. Sublingual immunotherapy is similar to oral immunotherapy, but you bypass first-pass metabolism in the liver by putting a drop essentially underneath the tongue. And then epicutaneous immunotherapy, the recent data was actually rather disappointing in showing it did not make a big difference when compared to placebo in promoting development of tolerance. That's where you take a patch that contains the peanut protein and place it on the skin for extended duration of time. So what does this tell us about tolerance? I think in my mind, the way that I see this is it's almost like a potter's clay. So the kiln is turning as a child starts to develop from 0 to 5 years of age. And once allergy is established, essentially that pot has been thrown in the kiln. And then it becomes difficult to break the changes that have been developed over time. So why hasn't this gained broader acceptance, this oral immunotherapy? This is Dr. Wes Burks, who's a mentor of mine, and really this has been the party line for essentially the past 15 years as many of these studies have been going on.
So the right thing to do right now is still avoidance. And if you have an excellent reaction, here's your antihistamine and your epinephrine, that's the right thing to do right now. The studies hold promise, but we're not there yet.
So not ready for prime time is the phrase that we've heard over and over and over about this therapy. And we're going to talk a little bit about why. So about 80% of people who undergo oral immunotherapy develop adverse effects. And most of those occur during the build-up period, but some even during maintenance when they've been on a stable dose of allergen. And 90% of those reactions occur at home. 42% experience systemic reactions, although the need for epinephrine is relatively rare. It does occur in some of these patients. And 49% experience GI symptoms, and a lot of the patients that drop out, we can attribute that to the gastrointestinal symptoms that develop. 1/5 of patients in all of these trials drop out because they cannot stand it. More importantly, I think, is a complication that's arisen and has also driven a lot of research questions for me is the development of eosinophilic esophagitis in some of these patients. So eosinophilic esophagitis is a food-driven condition, but it's distinct from IgE-mediated food allergy. But we have noticed that there are some patients who have IgE-mediated food allergy that are persistently exposed to a certain food protein that eventually go on to develop a new disease that did not exist before, and that's eosinophilic esophagitis. Based off the number of case series and case reports that have been published, there is a meta-analysis by a Spanish group, Lucendo et al., that estimated the incidence is about 2.7% of patients. But I think most people agree this is probably an underestimate because not all patients undergo biopsies. The majority of these patients, their symptoms will resolve after they discontinue the therapy. But it's something that really warrants further investigation and may provide key insights into the pathogenesis of another disorder, eosinophilic esophagitis. So let's talk a little bit about why there may be a link between those two diseases. First, if we think about the mechanisms of immunotherapy, you can see here, these are the immunoglobulin kinetics as well as some of the changes in different parameters that we see during oral immunotherapy. And what you'll notice is that for IgE, which is depicted in blue, you'll see an initial bump in IgE levels, and then they eventually decline. And corresponding with that, on the purple line, you'll see that skin prick test reactivity decreases over the course of oral immunotherapy. This parallels a decrease in basophil responsiveness. So by doing basophil activation assays, we can show that desensitization occurs relatively quickly during the course of oral immunotherapy. And we see a gradual decline also in T-cell proliferation. All of this coincides with a rise in food-specific IgG4 that increases over the course of oral immunotherapy. And we actually did a study on the COFAR egg oral immunotherapy trial where we looked at samples obtained from those subjects over a 4-year period. And these are the immunoglobulin kinetics, which I've already summarized in that other graph. But what you'll notice on the bottom 3 graphs is you'll look at egg white as well as its specific component proteins. They rise over time when you're looking at IgG4 levels. So let's talk a little bit about eosinophilic esophagitis. So the pathogenesis is poorly understood, but we know that repetitive antigen exposure plays a role because when you place patients on an elemental diet, these patients get better. About 90% of them will show dramatic improvement. Current forms of allergy testing are unreliable for diagnosing triggers. So skin prick testing, patch testing, serum Ig testing are not useful for diagnosing food triggers of this disorder. And esophageal biopsy remains the gold standard for diagnosis and measuring response to therapy. But there's recent data that suggests a possible association between eosinophilic esophagitis and the presence of IgG4. So there was a group at the University of Utah that was doing a study. It was actually a former mentor of mine, Jerry Gleich, and colleagues, where they showed that they showed that IgG4 concentrations in the esophageal biopsies of patients with eosinophilic esophagitis were dramatically increased. And I'd like to direct your attention here on the chart. You'll see that here you have the patients with eosinophilic esophagitis, patients that were normal controls, and you'll note that the eosinophilic esophagitis to control ratio for IgG4, when you look at the levels, there's 45 times more IgG4 protein present in the biopsy of patients with eosinophilic esophagitis. And these are pictures of that. This is depicted what I just explained graphically. You can see that IgG4 concentrations are much higher in EOE versus controls. And this is an immunohistochemistry study of patients that had eosinophilic esophagitis, and it's dramatic. It's intercellular deposition throughout the esophageal tissue in some of these patients. So we elected at the University of North Carolina, in collaboration with Dr. Evan Dellin, who has a large biobank of patients with eosinophilic esophagitis, to do a case control study where we took 20 adult subjects, and then we looked at patients who were responders to diet versus non-responders to diet, and we also compared them to non-EOE controls. And in the 11 diet responders, we determined their triggers, and the way that you determine the triggers for a patient with eosinophilic esophagitis is that you do repeated endoscopic biopsies after elimination. So we will eliminate the 6 most common foods, and we gradually introduce them 1 or 2 at a time. And if one of them results, if one food introduction results in the recurrence of eosinophils in the esophagus, that tells us that that food is a food trigger. So you have to do that over and over and over in order to determine which foods are the offenders. And what we found was that there was an increase in esophageal IgG4 that was statistically significant between the EOE patients and controls. So what we actually did was we took the esophageal biopsies, we ground them up, and then we measured IgG4 concentrations in a homogenate. In addition to that sort of corroborated the findings that were described by the Utah group, but we also looked at food-specific IgG4 because we thought that perhaps this might be a way to determine antigenic triggers. And what we found in the patients with eosinophilic esophagitis, they had dramatically increased levels of food-specific IgG4 within their esophageal homogenates for peanut, soy, egg white, casein, and wheat. We also did this for the plasma. We saw differences that existed that reflected what we saw in the esophagus, although they were not quite as dramatic. And what we found in the patients who responded to dietary elimination was, first, that the ones that responded to diet versus didn't respond to diet, there was no significant difference between those two groups. But when we looked at the pre and post biopsies in the patients who responded versus didn't respond, we saw a significant decline in total IgG4, whereas in those who didn't respond, the IgG4 levels did not decrease. There's also a difference in the responders versus the non-responders post-dietary elimination. When we looked at food-specific IgG4 levels for known triggers, we saw a dramatic decline pre and post dietary elimination. Then we tried to look to see if food-specific IgG4 levels would actually determine what the dietary triggers were for patients. And I've highlighted with stars the foods that were actually triggers. And what you'll notice for some of the patients, it works pretty well. The food-specific IgG4 correlates with the things that are known triggers. For milk, it seemed to work well for a couple of these diet responders, but there were some patients that were outliers, where they had very high esophageal food-specific IgG4 levels, and that didn't necessarily tell us what their food trigger was. We also had some patients where they had undetectable food-specific IgG4 levels to foods that were known triggers, and that may be due to the patchiness of eosinophilic esophagitis. The eosinophils don't always infiltrate to the same specific area. Interestingly, for the one patient who had soy as a food trigger, that patient did have an elevated food-specific IgG4 level to that food. And we did the same in the plasma, and the results actually paralleled fairly well with what we saw in the esophagus. So moving on, we're going to talk about a case presentation. I don't know how many of you see patients with eosinophilic esophagitis, but this is a pretty common example of a patient that we see on a regular basis. So I have a 17-year-old male with autism and eosinophilic esophagitis. He was diagnosed with eosinophilic esophagitis at 16 and was currently on dietary elimination, so eliminating milk, wheat, egg, nuts, seafood, and beef. His diet was fairly restricted to the foods listed, and he was on supplementation with an elemental formula to maintain his nutrition. So he had recently introduced Trix cereal into the diet, and the parents informed me that they had just changed the formulation of Trix according to the manufacturer's ingredient list, and he had developed symptoms of cough, decreased oral intake, and abdominal pain. They did an upper endoscopy that revealed mucosal changes, including a ringed esophagus in the upper third of the esophagus and middle third of the esophagus, and an ARIF grade 2 for rings, and I'll talk about what the ARIF means. There was eosinophils on his biopsy in the mid and upper esophageal biopsies. So he'd previously been followed at Cincinnati Children's. He had underwent a PPI trial and endoscopy before his diagnosis of eosinophilic esophagitis, and had between 15 to 20 endoscopies over the past 4 years to identify specific food triggers. I think I misspoke on his diagnosis. He was diagnosed at 13 years old. And his most recent upper endoscopy, gastroenterology had recommended viscous budesonide. So this gives you an example of how many procedures these patients have in order to try to identify their triggers, and highlights sort of the gap in knowledge that we have and the problem we have with our current diagnostic testing. So this is what they see when they do the endoscopy of these patients. And the endoscopic reference score encompasses several features that can be seen on the scope. So edema, rings, exudates, furrows, and strictures. And you'll see in this patient with eosinophilic esophagitis that it has this ringed appearance in comparison to the normal. You can see these white bubbling things along the side. These are the exudates that are formed. You can see that there's lines that run longitudinally along the esophagus. These are the furrows. And then there's also narrowing that can cause strictures, which are not depicted here. These patients also have mucosal fragility as well as narrow caliber esophagus, and all of this results in severe esophageal dysfunction or difficulty swallowing. These patients cannot swallow and they get food stuck in their throat, especially as they get older. So this patient had a history of IgE-mediated food allergy. He also had asthma, atopic dermatitis, and allergic rhinoconjunctivitis. On exam, he has some evidence of eczema, and he's obviously delayed because of his autism. But otherwise, his physical exam is not too normal, or not too abnormal. On his laboratory evaluation, his CBC shows a normal absolute eosinophil count. Labs are normal, and on his pathology, we can see evidence of the eosinophilia within his esophagus. So I've talked a little bit about eosinophilic esophagitis already, that it's an inflammatory disorder that leads to tissue remodeling, fibrosis, and esophageal dysfunction. Prevalence is probably between 1 in 500 to 1 in 1,000. And symptoms in children can be poor growth, feeding problems, vomiting, abdominal pain, difficulty swallowing. And as I said, in older children, teens and adults, we find food impaction. They'll come in with something that's gotten caught in their throat. So only way to diagnosis is with an esophageal biopsy. And treatment is with dietary elimination. And usually this is not just single foods. This is extensive dietary elimination, including foods like dairy, egg, wheat, soy, nuts, and seafood. Food groups. Swallowed steroids. We've actually sort of MacGyvered an approach where we take asthma inhalers or asthma nebulized formulations and tried to make them so that they stick in the esophagus. So we'll take nebulized budesonide, we'll mix it with Splenda, or with maple syrup or something like that to make it more viscous so that it coats the esophagus and reduces the inflammation that's present there. Elemental formula is also an option for supplementation as well as exclusive therapy in patients for whom we cannot get disease remission. But you can imagine what it would be like to only consume an elemental formula for the rest of your life. So the incidence is increasing. So you'll note that here we have a study that was done in Denmark by Evan Dellen and colleagues. And first at the top, you'll see that the biopsy rate they're trying to show that this is not just detection bias. The biopsy rate has increased about twofold in Denmark. And we see that there's been a dramatic rise in esophageal eosinophilia, a 25-fold increase. But when you account for the biopsy rate, there's been a 20-fold increase in the diagnosis of eosinophilic esophagitis. So the only way to monitor response to treatment is an esophageal biopsy. And so thus far, efforts to validate rapid, minimally invasive diagnostic markers have met with limited success. Some people have tried to look at ESGPs, or eosinophil secondary granule proteins, as a marker of eosinophilic esophagitis. And eosinophil cationic protein, eosinophil-derived neurotoxin, and major basic protein have all been evaluated in the bloodstream as markers of disease with mixed results. And this is essentially what an eosinophil looks like under an electron micrograph. So you'll see first, this is the cell with its bilobed horseshoe-shaped nucleus, and then in the cytoplasm you'll note that there's these granules that are present here. This is a close-up of one of those granules. At the center is major basic protein, and then in the matrix we find the ribonucleases as well as eosinophil peroxidase. And of those granule proteins, really the only one that's specific for eosinophils is eosinophil peroxidase. That comes from some of the laboratory work that we've done over at Mayo Clinic, where we showed that when you deplete white blood cells and you measure the concentrations of these granule proteins, when the concentration of the eosinophils goes to 0, the only granule protein that disappears completely is eosinophil peroxidase, whereas some of these other granule proteins are released by other cell types, such as neutrophils. So this makes eosinophil peroxidase really an ideal marker that's exclusive to eosinophils. So we've developed histologic scoring systems where we've utilized our novel eosinophil-specific reagents to evaluate patients who have eosinophilic esophagitis. And essentially what we're able to do is stain for this protein. Now when an eosinophil gets to the esophagus, it sits there, but then it also explodes. The majority of these cells undergo cytolytic degranulation, and what they do is they leave their granule protein products within the esophageal mucosa. And so by counting intact eosinophils, as is currently done on H&E stains, you may get an underrepresentation of the amount of inflammation that's present. Therefore, by staining for the granule protein, or the degradation product of the cell, you may actually see a greater extent to the inflammation that's involved in the esophageal tissue, and that's exactly what is shown here. You can see that there's eosinophils, but they're also releasing their granule proteins extracellularly, and so we get a better picture of what's going on. We've shown that this granule protein staining is actually very valuable and correlates better with symptoms than the current diagnostic metric of counting eosinophils per high-powered field. This is a study that came out of Cincinnati where they developed a validated patient-reported outcome measure called the PEAS questionnaire, where they are able to correlate symptoms with histologic findings that are present in the esophagus. And I'll just point out here, when we stain for eosinophil peroxidase, particularly in the proximal esophagus, the only one that has even moderate correlation with symptoms is granule protein staining for eosinophil peroxidase. You can see right here that eosinophil counts don't have even it's a pretty weak correlation. So we performed a study where we wanted to see whether serum eosinophil peroxidase could be used as a non-invasive marker of esophageal eosinophil-mediated activities, and we took 19 subjects with EOE and 20 patients that were non-EOE controls, and we measured other granule proteins in addition to eosinophil peroxidase using ELISA. We also looked at the same patient's esophageal tissues to see if we could see correlations between what was present in the serum versus what was present in the tissue. And what you'll note here first is that there's pretty dramatic differences between the EOE cases and controls with respect to peripheral eosinophil counts. So these are patients who have rip-roaring eosinophilic esophagitis. So in the tissue, they have 157 eosinophils per high-powered field versus 0 in the normal controls. And then the peripheral blood eosinophil counts were even statistically significant, different, with 363 eosinophils in the per microliter versus 195 in the controls. And this is what it looks like when you stain for eosinophil peroxidase within the tissue. You'll notice that in panel B, this is a normal control, and this is actually the H&E stain for the same patient. So there's nothing there. But when you look at somebody who has eosinophilic esophagitis, this is the H&E stain, and you can sort of pick up on the pink granule protein that are present on the H&E stain, but it's very difficult to quantify when you do it this way. But when you stain for eosinophil peroxidase, it becomes very apparent that there's extensive eosinophil inflammation that's present within the esophagus. When you score this in a systematic way, you can see that based off the reproducibility, patchiness, degranulation, as well as the eosinophil counts that are counted off that stain, that the total score is dramatically different in patients with eosinophilic esophagitis. So sort of unexpectedly and disappointingly, we didn't find any difference in the absolute levels of the serum granule proteins. And in fact, the patients with EOE tended to have lower eosinophil peroxidase levels than the controls. So this was a little bit confusing, but when we normalized them for the eosinophil counts that were present, it was really kind of fascinating. What we found was that there were actually lower eosinophil-derived neurotoxin levels and eosinophil peroxidase levels when you normalize them for the absolute eosinophil count. And so this suggests that there's sort of a regulation that when peripheral blood eosinophil counts expand, they hold on to their granule proteins so that they can retain them until they reach the site of inflammation. And this is just a dot plot showing the same thing that I just described in the chart. When we look at the ROC curves for these parameters, we can see that the diagnostic sensitivity is still not great, but the EPX normalized for absolute eosinophil counts performs comparably to the absolute eosinophil count. This is what happens when you correlate those peripheral blood levels versus the tissue eosinophil counts, and you'll see that there was an inverse relationship between the eosinophil peroxidase levels and the peak eosinophil counts in the esophagus. And one of the studies that we found as we were reviewing the literature that it kind of explains this is a study that used electron microscopy to look at eosinophils in the peripheral blood versus the tissues in various allergic disorders. And these are patients here that have asthma, Church-Strauss, and atopic dermatitis. And really these are normal eosinophils morphologically. But what you'll notice in panels E and F is that these patients have dramatic differences once the eosinophils hit the tissue. What you'll see here is that there's reversal of core protein staining in the granule proteins that are present in the cytoplasm. These are eosinophils that are ready to explode, and that's kind of how they look. But they retain their normal morphology while they're circulating in the peripheral blood. So the conclusions of this study were that the absolute eosinophil secondary granule proteins alone do not distinguish EOE subjects from controls, and that the normalized eosinophil peroxidase levels were inversely correlated with peak tissue eosinophil counts. So this is sort of a take-home slide that puts it together. So you have your eosinophil that's circulating, and it's releasing some granule proteins as it goes throughout the serum. This accounts for the normal absolute serum levels that we see. Somehow it receives a signal from the esophageal mucosa, and then it starts to hold on or retain its granule proteins, almost like a bombardier that retains its ammunition before it reaches the site of the war or the battle. And then we see an uptick in the number of peripheral blood eosinophils, and then they migrate to the tissue where they undergo cytolytic degranulation. So we're going to go back just briefly while we have a few minutes to talk about this connection between eosinophilic esophagitis and oral immunotherapy. We talked about how this is an emerging treatment for oral immunotherapy, and that desensitization is achieved in most, but there's many patients who have gastrointestinal symptoms, some of which develop eosinophilic esophagitis. So one of the things that's not been done and that's really important is to be able to examine the tissue in the esophagus during the course of oral immunotherapy, not just the esophagus, but the rest of the gastrointestinal tract. And we've had a remarkable opportunity to collaborate with investigators at Stanford University who are performing these oral immunotherapy studies, and we've been able to gain access to patients who have undergone serial endoscopic biopsies. So we have 20 adult subjects who at baseline, before they have any disease or before they have any problems, are having an upper endoscopy, and they have biopsy tissues obtained from the stomach, duodenum, and the esophagus. And then we're able to monitor the changes that occur over the course of oral immunotherapy. So there's biopsies obtained at baseline, 1 year, and 2 years. And we aim to characterize the eosinophilic gastrointestinal complications that occur using some of our novel approaches, including granule protein staining. And so I've explained sort of how we obtain those specimens, and then we've actually been able to quantify the degree of granule protein staining in these biopsies. And this is sort of the approach that we take. On the left, you'll see this is an H&E slide of a duodenal specimen from a patient with gastrointestinal eosinophilia. We use a different stain called the DAB stain, and everything in brown is eosinophil peroxidase deposition. By using a computer algorithm, we're able to quantify the degree of granule protein staining. And this is a false color markup of that same slide, and you'll see here that the pixels that are shown in red and orange are positive, are strongly positive for eosinophil peroxidase. And so that we can quantify that over a certain unit area, and that allows us to determine the degree of eosinophil peroxidase deposition. And so one of the surprising things that we found was that I have here the proximal esophagus, mid-esophagus, distal esophagus, and the peak esophageal eosinophil levels of these patients. And what you'll note is that I have a red line where there's 15 eosinophils per high-powered field, and this is the histologic criteria for the definition of eosinophilic esophagitis. Mind you, none of these patients have symptoms at the beginning of the trial, but what you'll note is at the very start of the trial, in the absence of symptoms, you have 3 subjects who have esophageal eosinophilia. They're meeting diagnostic criteria for eosinophilic esophagitis from a histologic perspective, even before they begin in the trial. So what that tells us is that there's a lot of patients who have IgE-mediated food allergy that are probably walking around with eosinophils in their esophagus. Now, some of them are not, now many of them, probably all of them, are not having symptoms. But I think it tells us something really important. The patient who's circled here in the middle at 1 year is the one who developed eosinophilic esophagitis. So this can help show us, interestingly, this is one of the patients who did not start out with eosinophils in its esophagus, but the eosinophilia was induced by the oral immunotherapy. But this pattern that's emerging, and seems to be really important, is that there's sort of a tenting phenomenon where you can see that some patients start out low, they go up high, and then it gets better, which tells us that perhaps eosinophilia may be an important process that occurs over the course of oral immunotherapy or persistent antigen exposure. And trying to understand what's going on is really the focus of some of our ongoing work. This is evidence of what's going on in the rest of the GI tract. So you look in the stomach and the duodenum, and this is the line where we diagnose eosinophilic gastroenteritis. So at 30 eosinophils per high-powered field, and what you'll notice is that there's a lot of patients that start out with evidence of eosinophilic gastritis in the stomach, and then it gets better on oral immunotherapy, whereas patients who start out low, it develops, and in some of them it tends to resolve. And the duodenum is a little less clear about what's going on there, but there's a lot of them that have evidence of eosinophilic duodenitis as well. So these are some intriguing observations, and they're leading to additional studies where we're trying to look at different subtypes of eosinophils. We've traditionally regarded these cells as a monolithic population, and there may be actually differences in individual cells with regards to their cytokine production and genetic transcription. Interestingly, when we look at IgG4 levels and compare them to EPX, we see strong positive correlations, which means that the IgG4 may be leading to the gastrointestinal eosinophilia or may in some way be related. So, one slide to put it all together. We have a patient who is atopic, who's predisposed to developing Th2 responses, and they can proceed down an IgE-mediated pathway and develop an IgE-mediated food allergy characteristic of the patient that I described. Or we have somebody who perhaps can proceed down an IgG4 pathway, which may be represented by eosinophilic esophagitis. And the link between these two may be repetitive antigen exposure, which drives IL-10 expression and favors IgG4 production. There may be homologs in other disease processes, so where you have an IgE-mediated allergy that results in allergic rhinitis, and then you have something that's similar where you have IgG4-related sinus disease, perhaps in the context of persistent antigen exposure. So you can see how this might relate to other disease processes. So what we need to try to understand is whether IgG4 is present there as the fire, or whether it's actually just a signal from the fire, or whether it's the immune system's efforts to try to abate the fire. So that's at the end of the talk. We have a question. I'm going to let you have a chance to text your responses. Early introduction of peanut in high-risk infants is an example of which of the following levels of disease prevention? Oops. Is it working? Okay. Everybody get a chance to respond? So the answer is actually secondary prevention. So this is a patient who has already had onset of disease, so they have risk factors including egg allergy as well as eczema, and many of these patients are already sensitized to peanuts, particularly the ones that have skin prick tests between 2 and 8 millimeters. So this would be an example of secondary prevention. So I want to acknowledge my colleagues at the Mayo Clinic, Jamie Lee, my mentor who passed away about 6 months ago, and then Matt Rank, my division chief at Mayo Clinic, Elizabeth Jacobson is my basic science mentor, my colleagues here at Phoenix Children's Hospital who have been great and wonderfully supportive of my research, Dr. Shauna Schroeder, Cindy Bauer, my technician Kelly Shim who's done most of the work, our resident who's working in the lab with us, Suzanne Barshow, as well as my colleagues at UNC and Stanford. And I won't talk about our future directions, but I want to leave the time for questions so that you can ask me if you have one. Thanks.
You mentioned that the guidelines were kind of withdrawn earlier in the talk about peanut allergy. Have they come out with newer ones?
Yeah, and so the guidelines that were withdrawn were the guidelines to avoid introduction of allergenic foods during the first 3 years of life. So the new guidelines is that algorithm I showed you, where we recommend if a patient has severe eczema, so if they're requiring consistent use of topical steroids, or they have refractory eczema that's refractory to treatment, or egg allergy, they should be referred to an allergist. Or you should perform a peanut-specific IgE test. Now, if that test is positive, it's really important that you refer immediately to an allergist, because we do have some patients that meet criteria for early introduction that can evolve, even within the time period of 1 month. So it's important to have those patients evaluated in the allergy clinic to see if we can introduce peanut or not. No. So the 2000 recommendation to avoid early allergenic foods was rescinded in 2008, but they didn't put forth recommendations for early introduction of peanut until just I think it was last year. And so the findings of the LEAP trial came out in 2015, I believe. So this is relatively new, but it's really important that you as pediatricians are on the front lines and that you make sure that these patients are triaged appropriately so that we can prevent this from happening. Yeah.
And then eventually, when the baby got a little better, they introduced peanut butter, and then it was positive. So that means that one has to have the food first before measuring the positive skin test.
Yeah, long question. I'll try to summarize it. So asking a question about the case is that, so the patient came in with an egg allergy, did not have symptoms with peanut, but really hadn't introduced peanut. And then the question was, does a patient have to have oral exposure essentially to an antigen in order to develop a peanut allergy, correct? And so the answer to that is patients can develop sensitization to food antigens without having been exposed to them. Now that's probably because they're being exposed to them in the environment through the skin, okay? So they've actually measured peanut protein in the house dust of patients who have peanut allergy, and there's elevated levels of peanut protein in their house dust. So what's happening is you're not feeding it to the infant. They've not been exposed orally, but they have been exposed from a cutaneous perspective, and that leads to sensitization. There's some evidence to suggest that even maternal exposure and in utero can provide enough antigen presentation to lead to sensitization to foods. I don't know if that addresses your question.
But in this particular case,
Mm-hmm.
see, the test was negative, but the baby had a high-risk history because of the family, had allergy.
Right.
And why did they introduce the peanut butter?
Why did they not introduce the peanut butter? That's a really good question. So this highlights the difference between what we see in studies and in the real world, right? So it's hard to get your child to eat peanuts on a regular basis. And so they may not like it, they may not think it tastes very well. And we actually have recipes in our allergy clinic that help parents to figure out ways to give enough peanut protein in order to promote the immunologic tolerance. What happened in this particular case is that they tried it for a couple of weeks and then they just got fatigued. They just stopped doing it. And despite our recommendations to do that to prevent peanut allergy, they didn't follow our instructions. And so I can't, why do patients not comply with our recommendations all the time? I don't know. As a patient myself, I know that I don't always follow my doctor's instructions.
My other question is this. I don't know what is the incidence of esophageal eosinophilic esophagitis in adults. Adults usually have had all type of food. Why it takes so long for them to develop eosinophilic esophagitis?
Yeah, that's a good question. So the question was, there are adults that are always consuming many different foods, and why do some patients present in adulthood with eosinophilic esophagitis? My answer to that would be, we don't know that it didn't present earlier. And so as we see in these patients who undergo oral immunotherapy, we're not seeing correlations with symptoms and the presence of esophageal eosinophilia. In other words, there may be ongoing immune reactions that are occurring in patients with IgE-mediated food allergies, or even in patients that don't have IgE-mediated food allergies that are going undetected, and it's not until there's some permanent immunologic damage with fibrosis that results in scarring and stricturing that results in symptoms. So it may be subclinical disease is the answer to that question. Yeah, so for our challenges, you'd actually, the person who knows best is Bernadette McNally in our clinic. We do sometimes use peanut protein powder, and sometimes we'll use peanuts themselves for estimates of the amount of peanut that's tolerable. There are new products that are out on the market who have tried to commercialize and capitalize on this venture where they've actually measured out grams of peanut protein powder, and so that is commercially available and can be mixed with things like applesauce or pureed with fruits in order to introduce those to young children, because a 4-month-old may not take very well to eating peanut butter itself, and so it's sort of easier said than done.